Welcome into another edition of Baton Rouge Ortho Talk. I'm your host, Matt Moscona, joined today by Dr. Bobby Easton. It's a pleasure to have you, sir. How are you?
Good yourself.
I'm doing fantastic.
Good.
These have been a great opportunity to get to know a lot of the BROC doctors and let our audience get to know all of you as well. So if I ask you, man, who's Bobby Easton? Where do you start?
Oh gosh, this is kind of a long story, but I'm kind of a transplant. So born in Detroit, but my parents moved to Houston at the age of 2. So grew up in Houston my whole life. Grew up in Cypress, Texas, kind of northwest of Houston, and I went to high school there. And then I was a gymnast my entire life. And then at the age of 16, quit and never played football or basketball or anything. So I was like, what can I do? So I started cheerleading and cheered my last couple years in high school. And then a good friend of mine's dad went to LSU. And he brought me to an LSU football game. And after that, I was hooked. So I came home after the football game. I looked at my parents. I said, I think I'm going to LSU. And they're like, you're what? So came to LSU and then met my wife when we were freshmen in college and been together ever since. And went to LSU undergrad and then went to medical school here in New Orleans. And then did a fellowship at the Cleveland Clinic and then back here practicing.
Okay, you were at LSU during a time, it would have been Jared DiNardo's years.
Correct. You got it.
So there were some good moments.
There were some good moments.
There were some not good moments, depending on when you fell in DiNardo. Any great memories of being down on the field for
it was
any of those
great.
games?
I was there for the when number 1 Florida came to LSU and we beat them, and everybody stormed the field. So that's probably one of the best memories. So, but yeah, we had a great time.
First time that LSU beat a number 1 team, and that was in 1997. I would imagine that if Dr. Easton could go back in time and watch masses of people being trampled, there's probably a few clients potentially on the field.
Yeah, it was like a sea of people just coming down. It was interesting.
Probably a little horrifying as well.
But it was good.
Did you always know that you wanted to be a physician, that you wanted to be an orthopedic surgeon?
I think medicine started intriguing me probably when I started at the end of high school, beginning of college. And then I was actually lucky enough to actually work for Baton Rouge Orthopedic Clinic back in the day when they were 2 separate clinics. And Dr. Plochet was there, and Dr. Kilroy and Dr. Strange, who played football. I was a kind of an X-ray tech, and I just helped roll cast and things like that when I was an undergrad. So I actually, it's kind of full circle because I worked for them in undergraduate at LSU, and then finally when I became a physician, I went back to their practice and started practicing with them.
So you knew when you were an undergraduate that this was going to be your path.
Correct.
Yeah. So it's always interesting also how when there's so many different subspecialties within orthopedics, to me anyway, how a doctor ultimately chooses what their subspecialty is going to be. Some people say, well, they like to do trauma because they do a lot of different things, or they know specifically because of an injury they had that drew them to that specific field. You do a lot of hip and knee replacements. What was it that led you down that path?
I think the biggest thing is when you see somebody walk into your office, whether they're in their 50s, 60s, even I have, for hip replacements, I have people as young as 16 I've done hip replacements on. And they walk into your office and they're miserable, they're in pain, they can barely walk. And then you do a hip or knee replacement on them, they come back with a smile on their face. They look at you and say, "You've given me my life back," and things like that. It's a great feeling. So I've also done some mission work with what we call Operation Walk. It's a gentleman out of Denver, and I've gone to Honduras and Panama. And the thing out there is that none of these patients have rheumatologic drugs and things of that nature. So you see 20-year-olds crippled by arthritis because they don't have drugs that we have here to treat rheumatoid arthritis and things like that. So you go over there, and it's just a gratifying experience to give somebody the ability to walk again.
A 16-year-old hip replacement?
Yeah.
Is that the youngest patient you've ever done a hip replacement?
Actually, I did one a little bit younger at 14. So.
What type of circumstance would arise to where someone in their early teens would need a hip replacement?
So one of the 16-year-old had leukemia, and from the chemotherapy drugs and things like that, the hip can undergo avascular necrosis. So what that means is the blood supply to the ball doesn't work anymore. So the head just kind of dies and just withers away, and it's pretty painful. So did that, and then there's some other hip things like hip dysplasia where the hip doesn't form appropriately. That causes people issues, and sometimes you have to do hip replacements on younger people. That's kind of the things that you're born with and things like that, or you get from drugs that you're taking to treat like cancer, things of that nature.
Sure. I think in my point of view, I would think typically when we're talking hips, it's maybe an elderly person would fall and break a hip. You wouldn't even think that it's something that could be so detrimental to a younger person, but clearly you see that in your practice.
Yep. Yeah. All the time.
I also found it interesting that your path took you to the Cleveland Clinic, which is one of the foremost medical centers in the world. It's an incredible place. I would imagine that coming out of your fellowship at the Cleveland Clinic, you would have had a lot of options. Why did you choose to come back to Baton Rouge?
I love Baton Rouge. It's Houston's too big for me, and ever since I've been at LSU undergrad, I've really loved this town and loved this place. And my wife's from here, and it's been great raising my children here and everything else. So it was the right thing to do.
Yeah, and obviously it's a great way to serve the community that you love so much. Let's maybe go a little deeper into hip replacements. We talked about the one sort of end of the spectrum, which is maybe I would say percentage-wise a bit odd, right? To see
Correct.
younger people.
Yes, correct.
What are the signs that typically point to people as they get up in age that would lead them to need to consider a hip replacement?
So I think the first thing is a lot of people, the hip, the knee, and the back are all kind of interconnected. So you kind of have to decipher where that pain's actually coming from. So most people with hip pathology, like in their hip joint, they complain of groin pain, kind of right here, right in the front of the hip. And that's kind of hip pathology and hip pain. If it's kind of more in the low back, posterior buttocks, that could be more back pain. And there are a lot of people who actually come in with knee pain because you have a nerve that innervates both the hip and the knee. And they might not have any hip pain at all, and you have to be astute enough to make sure you x-ray the hip as well, because sometimes people get injections in their knees and things of that nature, but it doesn't help. And if you don't go look at their hip, sometimes you can be kind of misled and fooled.
Interesting.
So, yeah.
So are there things that a patient signs aside from just I'm in pain that would lead them to know that I'm having hip issues? Pain,
decreased range of motion in their hip, inability to kind of, bend forward, tie their shoes, things of that nature, losing motion in their hip. If they hadn't had any trauma or anything like that, those are kind of the telltale signs.
How much of that could be, because for example, I think I have a desk job where I sit a lot, right? So your flexibility goes, range of motion goes. You have to be very cognizant of stretching. How much of, how could someone like me decipher if I'm having a hip issue or if it's just I'm getting old and not as flexible, lack of range of motion?
I think the biggest sign, again, is just that pain in your groin. If you don't really have pain in that front of your hip and in that groin region, you're probably a little stiff.
Yeah. I got, unfortunately, a life of football and then distance running in this body type.
Look, we all, none of us stretch enough.
I'm trying to get better. One thing that hosting this podcast series has done, talking to all the doctors, it has impressed upon me, I have got to spend at least 10 minutes, bare bone, just stretching a day.
I think the only person that stretches enough is probably T-Bob, but other than that.
He does plenty of that, no doubt. As you're treating someone, though, who comes in with hip pain, what is the process of trying to get someone to feel better, I would assume to put off surgery? I would assume that's going to be a last resort if possible.
Correct. So there's multiple options. So we would do an exam on the patient. We would take x-rays, see how bad the arthritis is, if it's early stage versus, ongoing where it's bone to bone. Once it gets bone to bone, you can't do as much. But the options are over-the-counter anti-inflammatories. Then you can do prescription anti-inflammatories. You can do physical therapy, but what people have to realize is you're not going to change the bony anatomy of the hip joint. So if you have arthritis, therapy can help strengthen the muscles up around the hip and give you a little bit more flexibility, but it's not going to change the hip pathology that you have. And then I think after that, you can try injections into the joint with a steroid. And then the end-all, be-all would be a hip replacement.
Yeah. What's typically a range of success whenever you talk about a joint replacement in the hip?
Joint replacement in the hip is probably about 90 to 95% successful.
Wow.
Yeah.
So in terms of reducing pain, eliminating pain all together?
Yes. All the groin pain that most people have goes away. And the nice thing about a hip replacement is you don't have to have a therapist. You can just pretty much walk with your walker, do some exercises at home, and you don't have to do a lot of therapy. With a knee replacement, you have to have somebody push you to get your motion back and things of that nature. So, if you took me to Vegas right now and told me I had to have a hip or knee replacement, I'd pick a hip replacement any day of the week over a knee replacement.
So downtime after hip replacement surgery, what are we talking about? It sounds pretty kind of cut and dried.
So recovery is 6 weeks to 2 or 3 months. You got to let the hip kind of scar into place and everything else. There's newer approaches where we move the muscles out of the way instead of taking muscles off the bone, which increases your stability and gives you a faster recovery. But it doesn't really change the body's heal time. It's still a 3-month process. But everybody's a little bit different. Some people at 2 weeks walk into my office and you can't even tell they've had anything done. Some people are still on a walker at 2 weeks, so it's just kind of patient dependent. But the overall is about 6 weeks to 2 or 3 months, and then a full year for still some aches and pains from time to time to go completely away.
So you said if you had to pick knee or hip, you'd go hip over knee.
Correct.
Let's talk a little bit then about knee replacements, which is a knee replacement the most common joint replacement?
Yes. Yeah. And the joint replacements, they're going to increase by about 300% in the next 15 to 20 years. So
why is that?
It's just a lot of people are getting them younger, with all the baby boomers and everything else, and it's a good procedure. Both a hip and a knee replacement are very good procedures to alleviate pain.
Does any of that increase? I would assume that also has to do just with acceptance of it as a result of positive results, but also
Correct.
advances in medicine. Has some of the technological advances made people more comfortable? Have you found that with your patients?
Yeah, I think so. But I think the other viewpoint is this. I think the mantra probably 15 to 20 years ago was you need to wait as long as you can and be as old as you can, because the joint sooner or later has a lifespan of probably 15 to 20 years on average, maybe up to 30. But people were worried about having to do that second surgery when if the plastic wears out or things of that nature. But I think the mantra now is would you rather be 50 and have 20 years of active life, or wait till you're 70 where you really can't do much and then get that knee or hip replacement then? So I think the mantra's changed a little bit to give people their quality of life back and have them productive during those years that they need to be productive and be pain-free.
That makes a lot of sense. Let's talk a little bit about the procedure itself about a knee replacement.
Okay.
What can someone expect? What do you tell your patients when they come in and you're consulting and saying, this is my recommendation, here's how it's going to go?
Okay. So pretty much, the surgery is, I tell everybody, less than 2 hours. And, for my part, it's probably about a 45-minute to an hour procedure. Most people think that we go in and we actually cut the bone way up here and cut the bone way down here and replace it all with metal. You can do that for like tumors and things of that nature, but I lessen it more to like capping a tooth in the dentist office. So all we're going to do is cut off the diseased cartilage, size the bone and reshape it, and then we're going to cap the end of the thigh bone. We're going to cut off the diseased cartilage off the shin bone and cap that as well, and then put a piece of plastic in the middle, and that acts as the new cartilage.
And that takes 45 minutes.
45 minutes to an hour, yeah.
So it's not quite as invasive as it used to be. Is that or is that how it's always been done?
It's always been done like that, but with technological advances as well as pain medication and intra-articular injections that we inject and everything else, there's probably about 30 to 40% of patients now that are being discharged same day that don't even stay in the hospital.
Wow.
Yeah.
After a knee replacement.
After a knee and a hip replacement.
So you also mentioned that people are getting them younger, which makes a lot of sense.
Correct.
I mean, I wouldn't have thought, I think, man, just put it off as long as you can. But
Right.
if you can eliminate pain and have an active lifestyle when you're still more active,
Right.
that makes a lot of sense. What about when your patient does that, and in that 15, 20-year span, they do start to see some wear in that artificial joint? Revisions, what is that process like?
So it could be a very small revision or a very big revision. So when I do joint replacements, I see everybody at the 1 year mark, 6 weeks, kind of follow them out the post-operative period. And then after that, we see them at the 1 year mark. And then we see them every 2 years after that. And the reason that is because the plastic in that joint can slowly wear out. Okay. The lifespan with the new plastics are probably 20 to 30 years, but you still have to watch it. The problem becomes if you came and you had a joint replacement and it was 30 years old and you started to have pain, what happens is as the plastic wears out, it releases little plastic particles in the body.
Mm.
Well, the white blood cells don't know what's plastic and what's bone, so then it eats the plastic, but then it also eats the bone as well. So you can get these huge kind of defects in the bone, and that we call that osteolysis. So I see my patients every 2 years, because if we can catch that plastic wear early, we do have to open the joint back up, but sometimes we can just take that old piece of plastic out and put a new piece of plastic in, and that's all we need to do. If you wait till you're painful, what can sometimes happen is it erodes the bone and loosens the implants as well. So then you have a much bigger procedure that you have to do on the back end.
So, like almost anything in life, continuing care is very important.
Yeah.
It's like a cap at the dentist. It's like, go see your dentist every 6 months. Like,
Correct.
it's an important thing to do. Like, get your teeth cleaned and make sure that you're taking care of your artificial joint.
Right.
Which that also feels like that's still every 2 years to check on a joint feels very minimal.
Yeah.
Like that wouldn't, and do oftentimes are those visits just, all right, you're good to go?
Correct. Yeah. Most of the time it's just an x-ray, checking on them, see how they're doing, and then kind of go from there. I tell all my patients we're going to be lifelong friends, because it's it's a process.
What about when there is maybe a more rapid acceleration of that joint deteriorating? Do you have to go back in and do maybe like a second joint replacement to replace that artificial joint?
Correct. Yeah. So that does happen. Sometimes over time they loosen. Sometimes they get infected. Things of that nature. So sometimes you have to go in there and do those kind of things.
Is that something that happens commonly, or?
I would say it's probably less than 10%.
Okay.
Yeah, it's not too common, but it's out there.
It's a bad luck of the draw if it happens that
correct.
way. We've talked knees, we've talked hips. You also deal with femoral neck fractures as well.
Correct.
What is that?
Okay, so pretty much a femoral neck fracture, that's something you most of the time see in an elderly patient. Every once in a while you can see it in a trauma patient, high energy velocity in a younger patient. If the patient's younger, we're going to try to fix those, because we want to try to conserve the normal hip joint for that patient. The problem is most of the time for an elderly patient, once the ball displaces off the neck, so you have the shaft of the thigh
you got to help
bone.
me. I thought we were literally talking about our neck.
No, we're talking about the hip.
This is still in the hip. Okay, so what is the femoral neck?
You have the shaft of the thigh bone,
okay,
and then you have a neck that kind of comes up at a 45-degree angle, and then you have the ball. Okay, so a femoral neck fracture is right where that neck is, in the middle of the neck, and then the ball displaces off.
Oh, wow.
The problem, though, is once that ball displaces, the blood supply is coming in from the bottom up to the top of the head. So once it displaces, the blood supply to that ball isn't really that good anymore. So what happens is, if I go back in and try to reduce it, and what I mean by that is put it back in alignment and put screws or plates or anything else, sooner or later that blood supply to the ball is not going to work. And then we have, again, what we talked about a little bit earlier, avascular necrosis. So the ball is just going to wither away, necessitating a hip replacement. So most of the time when we see these femoral neck fractures in elderly patients, we just go straight, and it's displaced, we go straight to a hip replacement.
Is that what happened to Bo Jackson?
Yeah.
That was the Bo Jackson injury?
That was the Bo Jackson injury.
And as I recall, well, actually, would you describe what happened there? Because you could do it in a far better way than I can.
So for Bo Jackson, I'm not quite sure if he had a femoral neck or if his hip just purely dislocated. But anytime the hip dislocates or you have a fracture on the hip joint, you can lose blood supply. So they went back in, if I remember correctly, they fixed Bo Jackson at first. And then he probably, again, same thing happened. He went on to what we call the avascular necrosis, where the blood supply doesn't work anymore. And then that necessitated the hip replacement.
Right. It never healed. So he ended up having a replacement.
Correct.
And still went on to be a two-sport athlete after
Correct.
that, because, he's a total freak show,
Yes,
and he's
exactly.
Bo Jackson. I would assume most of your patients are not Bo Jackson.
No.
That come in that have that type of an injury, can go back on to play Major League Baseball and slug 450-foot homers.
Yes.
Is that something that you do commonly see in elderly patients? Or you mentioned like high velocity
Correct.
injury. What would constitute something like that?
Car accidents, things of that nature. People who do have dislocations of their hip from a trauma, or if they have a pelvic fracture with a dislocation, we try to fix those. The trauma guys try to fix those. But again, sometimes the blood supply to that ball in the hip joint doesn't work from secondary to the trauma. So then it would necessitate coming back sooner or later and doing a hip replacement as well.
When you think about your career, 2 decades thereabouts now, what what are some of the things that have been really exciting developments in the last 20 years?
I think a lot of it's just how we treat joint replacements and everything else. When I first started practice, and even before that, probably 20 years ago, if you got a joint replacement, you were in the hospital for like 5 or 6 days after the joint replacement. I think with technology being so good and the implants being made so well, and then the injections we use, and then we treat pain on multiple pathways to try to decrease inflammation and decrease pain. A lot of these patients do really well really quick.
Yeah, I- I've had procedures at BROC,
Yeah.
done at BROC. The recovery time is something that really even surprised me. I went home the same day
Right.
when I had a knee surgery. I didn't have a replacement, but I had a knee surgery. I was home the same day. And the other thing is, you know, I felt like I got exceptional world class care here in Baton Rouge. As a guy who's been all over, and we mentioned was a fellow at the Cleveland Clinic, can you speak to the all of the resources available at the Baton Rouge Orthopedic Clinic? Because it's pretty amazing.
Yeah, it's really interesting because we're a tertiary referral center for everything. I have patients coming from Mississippi. I've had patients come from New York to see me. And the nice thing about our group is we all subspecialize. We have every subspecialty covered, from tumor to trauma to spine to hand. And we all just kind of operate in our niche field, and we do what we do, and we do it the best. And the thing is it's one of these things where I can do a carpal tunnel, I can do a lot of things, but why am I going to do that when I got a guy down the hall who does 1,000 of them a year?
Right.
It just doesn't make sense.
Right. It's an amazing resource in this community. BROC is. If I asked you to look at the other end of the spectrum of the question I just asked, the advancements in 20 years, do you ever allow yourself to think about what medicine will look like in another 12 months, 24 months, 20 years?
Yeah, it'll be interesting. I don't know for sure. There's a lot of push, a lot of financial pressures, things like that. So we'll have to kind of see where everything goes. But I think hopefully everything will be still driven. There's a lot of physicians now being hired by hospitals and things of that nature. I think the beauty of it is with Baton Rouge Orthopedic Clinic, we're one large group, and we're subspecialized, and I'm very humbled, and at the same time I have to work. I don't want to go punch a clock. My phone's on 24/7. Patients call me all the time. I work 7 days a week. I see my patients every day unless I'm on vacation, and we have that kind of mentality. My fear is as in 20 years, people might be more on the clock than worried about medicine's changing. But I think if you take care of the patient and you're available, and you always say yes, think good things will happen.
It's been a pleasure. We appreciate the time today.
No problem.